Hello and welcome to this lecture. Today we are going to discuss histamine and antihistamine drugs, and I am presenting a case of an 8-year-old girl is brought in by her mother for evaluation of allergies. Each year in the spring the child develops a runny nose, itchy, watery eyes and sneezing. She has been treated in the past with diphenylhydramine, but the child teachers say that she is very drowsy during school. She has no other medical problem and is on no chronic medication. The physician diagnosed her with seasonal allergic rhinitis and prescribed fexofenadine, which is an antihistamine drug. So we will discuss today about histamine and antihistamine in today's lecture. So before starting my lecture, I am going to show you one video on histamine. We already studied histamine in our pathology and physiology before, so I am going to revise you about what is histamine, and then I will explain in detail.
Histamine, friend or foe, or frenemy. From NIH Medline Plus magazine. Histamine. Is it the most annoying chemical in the body?
Plant.
It's the stuff that allergies are made of. Hay fever, food allergy, skin allergies. Histamine plays a big role in all of them. And those conditions play a big role in us. In 2015, CDC data showed that more than 8% of US adults had hay fever. More than 5% of US children had food allergies, and at least 12% of all US kids had skin allergies. So what's the deal? Why do we have such a pesky chemical in our body? Well, histamine is usually our friend. Histamine is a signaling molecule sending messages between cells. It tells stomach cells to make stomach acid, and it helps our brain stay awake. You may have seen these effects illustrated by medicines that block histamine. Some antihistamines can make us sleepy, and other antihistamines are used to treat acid reflux. Histamine also works with our immune system. It helps protect us from foreign invaders. When the immune system discovers an invader, immune cells called B cells make IgE antibodies. The IgEs are like wanted signs that spread throughout the body, telling other immune cells about specific invaders to look for. Eventually, mast cells and basophils pick up the IgEs and become sensitized. When they come in contact with a target invader, they spew histamine and other inflammatory chemicals. Blood vessels become leakier so that white blood cells and other protective substances can sneak through and fight the invader. Histamine's actions are great for protecting the body against parasites. But with allergies, the immune system overreacts to harmless substances, not parasites. id.nih.gov.
So when we talk about histamine and basic pharmacology, it is actually synthesized in 1907 and later on isolated from the mammalian tissues. So this is actually naturally present inside the tissues and that were isolated from the mammal tissues, and it have a number of physiological roles. Like histamine is very important, especially symptom for anaphylactic shock. If somebody have tissue injury or anaphylactic shock, it could occur because of the production of histamine in the body. So it is a very important clinical indication or clinical marker to identify the allergies. If somebody have allergies such as, for example, urticaria or any inflammatory reaction, so histamine plays an important role in that. And secondly, histamine also plays an important role in gastric acid secretions. So when you take a look of the slides, you found that their origin is from the plant and animal tissues, and they also present in the venom and stinging secretions. What is meant by venom? It means that if any insect bite the patient, or any snake or any insects or any arthropods, then it can trigger histamine. Then it is also important marker for systemic mastocytosis, arteria pigmentosa, gastric carcinoid, and occasionally myelogenesis leukemia. So it is very important biomarkers for tissue injuries, like obviously gastric carcinoid or urticaria is an allergic condition, or any tissue injuries could lead to the production of histamine. So where histamine will be stored? It's stored inside. You have to understand the mast cells. The mast cells is very important for the storage and release of the histamine. So we have to understand that the histamine is stored in the mast cells and is released through several mechanisms. Number one mechanism is, I mentioned here, is immunologic release. And when we talk about immunologic release, we need to understand that the process where, if for example there will be a tissue injury because of the allergens, such as for example some people are allergic to some fruits, some foods like peanuts, as you have seen in the previous video as well, that it can activate IgE antibodies. And if you remember in the asthma as well, we discussed that the formation of antigen and antibody complex will be formed. So this is also known as immunologic release, and this could be occur because or during of IgG or IgM mediated immune reactions that activate the complement cascade, which is responsible for the release of histamine from the mast cells and the basophils. So we need to understand that the chemical or mechanical mast cell injury also causes to release histamine. I already mentioned, if somebody have tissue injuries, for example some insect bite you, some chemicals that accidentally split on your face or on your hand, then it could release histamine. And if you remember, when we discuss in pathogenesis and we discuss in the etiological factors in pathology, if you remember that lectures, would go back to the pathology, we already discussed that causative agents, and we discussed about the chemical causative agents or mechanical injury. They also are responsible for the release of histamine. So the main thing is that sometimes some chemical factors, mechanical factors are also responsible to release histamine. Furthermore, then obviously some drugs are also responsible to release histamine as well. And how this process occurs, that it starts from degranulation, and that degranulation is responsible for the release of the histamine. We already discussed in pathophysiology in our previous lecture, so I'm not going to go for detail, and that's why I put a video for this topic in the beginning so that you can memorize your past knowledge. When we discuss about pharmacodynamic properties, we need to understand the histamine receptor subtypes. There are 4 types of main receptors: H1, H2, H3 and H4. If you see on the left side, we mentioned receptor subtypes. So these are H1, H2, H3 and H4. And till now we are moving towards the week 12, and we always discuss pharmacology in terms of their receptors and their distribution of the receptors in different body tissues. When we talk about the H receptors, they have been distributed in various parts, like smooth muscles for H1, endothelium cells in the brain. H2 receptor is on gastric mucosa. That is important. That is why when we classify antihistamine into H1 and H2, they both having different functions, because H1 is on the smooth muscles, whereas H2 is on gastric mucosa, and that why it is used in dyspepsia. So that you have to understand the distribution of the H2 receptors in the gastric mucosa or in the cardiac muscles or mast cells or in the brain. Then H3 and H4 are usually uncommon. They are not, the drugs are used is not so common. They acting on actually neurons, presynaptic, autoreceptors, heteroreceptors, brain and myenteric plexus, whereas H4 act on eosinophils, neutrophils and CD4 T cells. And when we take a look of the mechanism of action, they are acting on different, you can say that, neurotransmitters. Like when we talk about H1 receptors, they are acting on GQ. And then what is GQ? It is actually the G protein receptors, but GQ protein receptors. And then we have inositol triphosphate, IP3, then DAG, which is diacylglycerol. So this part, post receptor mechanism, is discussing about their actions and they all four act on G receptors, GQ or GS or GI receptors. And then you need to see that the H2 receptors, when they act on H2 receptors, they can increase cyclic AMP, whereas in H3 receptors in the heteroreceptors brain or myenteric plexus or other neurons, the cyclic AMP is decreased. So their function will be depend upon their site, their receptors and their distribution in the body. And then H4 receptors also decreasing cyclic AMP that act on eosinophils, neutrophils or helper T cells, CD4 cells. So the drugs that has been partially selective agonist, we mentioned some of the name of drugs like here, histoprofedin, amthiamine. Then we have some other drugs like I mentioned here, imipib, methyl histamine, whereas we have partially selective antagonist or inverse antagonist drugs like this actually, because the main thing is that the agonist we usually don't use it. It is not usually involved, because obviously when what is meant by agonist mean that these drugs are promoting to produce more histamine, and usually in medical conditions usually we don't use much, but actually our target is this one. This one is important because if there is immunological reaction, allergic rhinitis is the common example. Then if for example patient having dyspepsia, then we need to use these agents, and more specifically we use H1 receptor antagonist like I mentioned here, and these are the drugs. Cetirizine is the most commonly drug. Then the cimetidine is very common, ranitidine is very common for treating the peptic ulcer. So these two classification are used the most commonly one, whereas H3 and H4 we have been some drugs but not been commonly used. So I have been more focused on H1 and H2 receptors antagonist. So the histamine affect in which organ and systems and tissues? So we have different effect on the nervous system, on the cardiovascular system, on the bronchiolar smooth muscles, gastrointestinal tract smooth muscles, other smooth muscle organs, secretory tissues, metabolic effects and triple response. So they have a wide variety of effects on different tissues and organ system. And why it having a different effect? Because it depend upon their receptors. As I already see, if we go back, that H1 receptors has been present in smooth muscles. So smooth muscles are present in various tissues and various organs. So that's why the effect will be quite broader effect. And when we talk about the effect on the nervous system or neurons, is why? Because H3 receptors are present in the brain, with H1 and H2 also present in the brain. So that is why the effect is quite generalized, and if you see their effect is on the nervous system, number one is very common. Then it have the effect on cardiovascular system. Then bronchiolar smooth muscles, especially for treating the asthma. Then gastrointestinal smooth muscles, yes, it is important for dyspepsia. So you can see that if you need to memorize these drugs, or you need to memorize the effect, you need to memorize them by knowing them, the receptors that are present. So nervous system, why? Brain. Cardiovascular systems, because it affect on the smooth muscles over there, bronchiolar muscles on the asthma, gastrointestinal tract, because it is responsible for treating dyspepsia. It can increase actually the histamine release and can cause increase acidic concentration. Bronchiolar smooth muscle, it can cause severe asthma as well. And all smooth muscle organs, wherever the smooth muscles are there, it could affect them. Then it can affect the secretions, it can cause increase of the secretions. It can affect the metabolic effect. So what will be the triple response? The triple response is like red line, flare and wheel. So if you remember pathology, we discussed the triple response in the previous textbook, so please go back and read them. Then the toxic effect of obviously the histamine is responsible for flushing, hypotension, tachycardia, headache, urticaria, bronchoconstriction and gastrointestinal upset. So the drugs, especially obviously when we talk about histamine, it is contraindicated in asthma, ulcer disease and gastrointestinal bleeding. So actually the main focus is on about histamine antagonist, and we have different type of histamine antagonists. One are physiologic antagonist like epinephrine, we already studied in our previous lectures. Then we have release inhibitors like cromolyn and netcromolyn. Then we have histamine receptor antagonist, that is our main focus on. So we are discussing only histamine receptor antagonist. We already discussed the previous one, especially the epinephrine and cromolyn and netcromolyn in our previous other classifications. When we talk about H1 receptor antagonist and we discuss the pharmacology, we classify them into two types. One is first generation and second one is second generation. And the common example in first generation is diphenylhydramine, whereas in the second generation the common example is cetirizine and fexofenadine. What is the difference between first generation and second generation? The main difference between first generation and second generation is the sedative effect. First generation have more sedative effect. Patient can feel drowsiness or sleepy as compared to the second generation, which is less sedative. And why this happen? Because first generation have more effect on the central nervous system as compared to the second generation. When we talk about the second main difference is the duration of action. The duration of action in first generation is 4 to 6 hours. It means that it is short acting, whereas the second generation their duration of action is 12 to 24 hours. So when we need to take cetirizine as tablet as an anti-allergic, many times if you go to the doctor and you have allergy, doctor prescribes cetirizine as an anti-allergen and usually take 2 tablets for 1 day. But when we need to take diphenylhydramine, we need to take more drugs 4 times in a day. So that's the main difference between both of them. And diphenylhydramine is sedative effect, and that's why in a number of cough syrups diphenylhydramine also present, and that's why when you take the cough syrup you always feel drowsiness. That's because of the drug that is there. Let's discuss the pharmacodynamic effects. There are so many effects of when we talk about H1 receptor antagonist. Why? I already discussed that the main reason is that smooth muscles actions. They affect wherever there are smooth muscles and they affect on that. And again repeating the same thing, that when we need to understand the receptors pharmacokinetics or pharmacodynamics, especially we need to see that the drug effect on which receptor. So that's why if you take a look of all these effects, there are so many. Like number 1 is the reversible competitive binding to H1 receptor. It means that it binds to H1 receptor antagonist. It is an H1 receptor antagonist in simple words. Then it can cause sedation effect. Why? Because the receptors on the brain, CNS effects. Then it has an anti-nausea and anti-emetic action as well. Then it has an anti-Parkinson effect as well. It also have an anti-muscarinic actions. It also have an adrenoreceptor blocking action. Then it also have serotonin blocking action, and it also acts as local anesthesia. So there are so many effects, but the main effect that we use this H1 antagonist is used in the treatment especially for allergic rhinitis. And let's discuss in one table. I will show you one table to see that how it would look like. If we take a look of this table, on the left side we have list of drugs, and their drug classification depend upon the chemical structure of the drug. So again, as you are not familiar with the chemistry, I am not going to go for detail, but the classifications like ethanolamine, piperazine derivatives, alkylamine, phenothiazine, these all names are given or classified according to their chemical structures, and these are the list of the drug that has been available. Along with on the right side you see the dosage. The usual adult dosage has been mentioned, first generation and second generation both. And in the third column they are talking about anticholinergic effects. Some are having high anticholinergic effects, and due to its high anticholinergic effect you can see the effect like anti-emetic. As if we go to the previous slides and the pharmacological effectivity, they are talking about a number of anti-nausea, anti-emetic action, and these all actions are because of these anticholinergic effects. When we take a look on the right side on the comments of each drugs, they are talking about different activities in the comments, like ethanolamines, they have slight to moderate sedation, and then with some other drugs they have some marked sedation and anti-motion sickness activities. So the activities of each drug in each classification is slightly different. Some are slightly sedative drugs, some are moderate sedation. So it is, there is not comparison, there is no comparison. When we take a look at second generation antihistamine, and the drugs that we have is more commonly used like fexofenadine, and on the right side there is no comment, so it having very less sedative effect. And the other drugs, loratadine is another drug which is very common, and it having long duration of action as compared to the other drugs. And the third example they give is cetirizine. So the second generation antihistamine are now more commonly used. The drugs that has been available in the market, there are so many, like expectorant. I think everybody if they use the Western medicine, they are familiar with the name of this drug. It is used as to treat cough syrup, expectorant, antihistamine. Then another drug that is used to dissolve phalgum, or in simple words sputums, is rhinathiol, that contain promethazine. Then for allergic rhinitis, actually the most of the drugs that has been used in this category as an antihistamine, although it have a multiple effects as an antiemetic action as well, but allergic rhinitis is the commonly used, especially antihistamine, especially Telfast D is the example, and that contains fexofenazine. And you can see it is used for treating runny nose, sneezing, itchy, watery nose, eye, throat, blocked nose. Then we have another drug which is loratadine plus pseudoephedrine. It is used in combination for aliperidate. So when we take a look of clinical pharmacology of H1 receptor antagonists, they are used for treatment of allergic reactions. It could be for treating anaphylactic shock. It could be used for treatment of especially allergic rhinitis. It is also used for motion sickness, like it because of its antiemetic activity and vestibular disturbance, which is responsible to balance the body. Vestibular system, we all know it is responsible to maintain the balance in the body, so you can see the physiology. And it is also used for the treatment of nausea and vomiting, especially in pregnancy. Some woman faces nausea and vomiting, or traveling diarrhea, traveling sickness as well. So the drug has been used for the treatment of these following activities. The toxicity include in this classification of drugs are sedation, antimuscarinic effect, excitation and convulsions in children, postural hypotension, and allergic responses. Let's discuss the drug interaction. And the drug interaction in this classification is ketoconazole, itraconazole, macrolides, or erythromycin. And especially the ketoconazole, itraconazole, or macrolides, these antibiotics, they can interfere the metabolism of drugs, especially H1 receptor antagonist. And what actually happened that antihistaminic drugs, especially the drugs like second generation drugs, they metabolize with the help of cytochrome P450 enzyme. And what ketoconazole is doing, that ketoconazole and the drug that I have mentioned here, they block the enzyme, and as a result, when they block the enzyme, it increases the concentration of the drug, especially second generation drug. And at the end, the consequence will be there will be increased concentration of the drug. So when we talk about grapefruit as well, same process, because grapefruit also responsible for interfering the metabolism process, and that's why. And the driving under operation or driving our operating machine is also prohibited, because they can affect, because if a person is taking H1 receptor antagonist, it having a sedative effect, and if the drug having sedative effect, then it could lead to drowsiness or sleepy, and then patient unable to operate the machinery. Let's take a look of the treatment for allergic rhinitis. This is a clinical management diagram. As I mentioned before, that H1 receptor antagonists, they are usually used for treatment allergic rhinitis, and we know that we can give H1 receptor antagonist, but it is not always, because it depends upon patient condition. So for example, if you take a look, if for example patient having allergic rhinitis, we need to avoid the symptoms why this occur, which is the causative organism, which it occur by food, pollen, or what is the etiology of the disease. Then initially, if the symptoms are mild, we can give second generation oral or trans or intranasal antihistamines. If the symptoms are mild to moderate but persistent, then we can give intranasal corticosteroids. So if you study corticosteroid, remember we give this corticosteroids in allergic rhinitis as well. So what happening that if the conditions are mild to moderate persistent symptoms, then we can give intranasal corticosteroids alone as first line of therapy, and then along with we can give the nasal irrigations, nasal decongestions. We can give intranasal antihistamines like Atrovent as well, or we can give oral or intranasal antihistamine for persistent nasal ocular symptoms. So we need to see the symptoms. If the symptoms are severe and persistent, then we can give intranasal corticosteroids, oral and nasal antihistamines as well, plus leukotrienes antagonist like cromolyn. And if the symptom persists, we can go for the immunotherapies like IgE mediated immunity, or we need to see the alternative treatment. We need to avoid the causative organism that why this occur, like we mentioned here, allergen avoidance, nasal irrigations, acupuncture also used for treating this, then probiotics or herbal preparation we can give, because in case of the symptom persist. So we need to give patient depending upon the patient status. You can click on this link that I give to you for more detailed information. When we talk about H2 receptor antagonist, it is used for the treatment of dyspepsia, and it is used for treatment of peptic ulcer disease. Most common example is cimetidine, famotidine, nizatidine, and ranitidine. And the mechanism is that very simple, and it is responsible for blocking the binding of histamine to H2 receptors. As if you go back to my previous table, in this table we already mentioned that the H2 receptor are present in gastric mucosa, and then the drugs we give cimetidine, ranitidine. So they are responsible for decreasing the peptic secretions and for the treatment of dyspepsia. It is used for gastroesophageal reflux disease, GERD, peptic ulcer disease. The side effects could be anti-androgenic effects. What are anti-androgenic effects? The anti-androgenic effect like sexual dysfunction or gynecomastia in males is the common examples. Why it occurs, the mechanism is still unknown. Then it could cause headache, or it can decrease the hepatic metabolism of certain drugs such as warfarin, anti-epileptic drugs, or oral contraceptive. So we need to avoid the drugs when we give warfarin or anti-epileptic or oral contraceptive with the H2 receptor antagonist. This is a drug is present in the market. When we take a look of this table, especially the clinical management of H2 receptor antagonist and for the treatment of dyspepsia and ulcer, this is a quite long table, but let me explain to you one by one. So if for example is patient is presenting with ulcer-like symptoms, we need to see first that whether there is dyspepsia, or for example no alarm symptoms, or alarm symptoms like bleeding, anemia, or weight loss. So first we need to see that the patient condition, whether the symptoms are alarming, which consist of bleeding, anemia and weight loss. If for example patient only have dyspepsia, no alarming symptoms, then we need to see that whether the patient is on NSAID or not, because sometimes what happen that the drug like NSAIDs, which is non-steroidal anti-inflammatory drugs, can possibly cause dyspepsia. So if for example patient are on NSAIDs, we say that yes, then we need to stop the NSAIDs, or if it is necessary we need to decrease the dose. So that's, we need to see this is a mechanism first, that if patient on NSAIDs, it could be one of the reason for dyspepsia. If for example is not on NSAIDs, we need to see the clinical history, then we need to see that previously patient treated with H. pylori or not, because if patient is treated with H. pylori, then we need to see the serology. We need to test whether the patient is still having H. pylori or not, because H. pylori is another etiology that can cause dyspepsia. If patient having no serology, it means if patient having no H. pylori and patient having a negative, then we need to see that we need to give them H2 receptor antagonist or PPI, which is known as proton pump inhibitors. And if patient for example stop NSAIDs for example, and then symptom resolves, then patients solved and they don't need to do anything. But if patient symptom persist, then we need to give them H2 receptor antagonists or proton pump inhibitors. And then both are, if you can see, core link. First we need to see whether the patient is suffering from NSAIDs treatment. If NSAID treatment yes, then reduce the dose or stop the dose, but if still persists, then proton pump inhibitors or H2 receptors antagonist or PPIs. Say still if patient symptom persist, then you can see that we can use, like you see, if still persist, we need to go that this arrow, if you take a look of this arrow, we need to go for endoscopy. Yeah, I just cut this picture. So we need to see and assess the patient ulcer situation, what is the situation. But if symptoms resolve, then we can continue or we can discontinue the PPIs or H2 receptor antagonists. So this is the one way, and this way is about NSAIDs, or if patient is H. pylori infected, and we need to see the patient serology to test whether this have. If patient having, for example, have H. pylori, then again we need to treat, we need to see the other regimen. On the other side, if you go back to this condition where patient having alarming symptoms like weight loss, bleeding, we need to access through endoscopy, as we need to see and assess the patient condition. As you see, if still persist with H2 receptor antagonists and PPIs, we need to go for endoscopy. So this is if patient is diagnosed that the dyspepsia caused by NSAIDs or H. pylori and still untreatable, then we need to do endoscopy and we need to find out the reason behind. If we see that in other case patient come with the bleeding, anemia and weight loss, endoscopy is necessary. We need to see that if ulcer is present or not, and if ulcer is absent, we need to see the etiology such as GERD, gastrointestinal reflux disease or NUD, and non-ulcer disease. And then if for example patient ulcer present, we need to test for H. pylori as we done on the left side as well. If it's treated with positive with H. pylori, then we need to give them the medicines, treat with H. pylori eradication regimen, PRI based H. pylori eradication regimen. If patient having negative, then we need to see whether it is on NSAIDs. If NSAIDs, then discontinue NSAIDs and treat with proton pump inhibitors. And if patient having H. pylori, then we need to see the symptoms for 1 to 2 weeks with post treatment. And then if the sign persists, then we need to see, we can give NSAIDs antibiotic resistance and non-adherence and other diagnosis, because obviously if H. pylori has not been treated, then we need to see whether maybe that patient has been resistant to the treatment if the antibiotic is not effective. If for example ulcer is absent, then we need to see the other reasons. Then we have H3 and H4 receptor antagonist, and it consists of, it could be for especially for narcolepsy or obesity or cognitive or psychiatric disorders, especially H3 receptors for using for sleep disorders. For H4 receptors blockers especially used for chronic inflammatory conditions such as asthma, in which eosinophil and mast cells play a prominent role, or it is used for the treatment of pruritus, asthma, allergic rhinitis and pain condition as well. So thank you so much for today's lecture. Hope to see you again.